Welcome to Part 3, Non-Intentional Childhood Injuries. This is a fairly short one in comparison to the last one, and this is going to be about shock. There are a variety of causes of shock in a child as well as in an adult. So hypovolemic shock can be a result of blood loss, dehydration, as well as sepsis. Poor perfusion type shock is due to an anaphylactic reaction or sepsis. And then we have cardiogenic shock, which is because there's a decrease in the cardiac output that leads to either dysrhythmias or we have congestive heart failure. No matter what the type of shock, the ultimate response is going to be the same. We're going to lose the blood pressure, the tissue becomes hypoxic, and the child develops metabolic acidosis. So we have compensated and uncompensated shock. And the compensated is this child is trying to get better on their own, and they can only do this for so long, and then all of a sudden all of their reserves are gone. So a child who is compensating still has their organs functioning fairly well. Not at 100%. They're showing signs of distress, but they're still doing it on their own. So they're irritable, they're apprehensive. They have tachycardia, and you don't know why because they don't have a fever. Even when a child is septic, they do not always have a fever. Normal blood pressure at first, and that's why you need to continually reassess them, is to look at the trend. Are they holding their own, or are they starting to go gradually downhill? We see a narrowed pulse pressure. They start becoming pale because they're going to perfuse more to their vital organs, but not to the periphery. They start having thirst because they're retaining the fluid. They have decreased urine output, decreased peripheral perfusion, and that's why their skin is cool. So uncompensated, we're beginning to see the signs and symptoms of circulatory collapse. As a result, tissue hypoxia is present, the acidosis develops, and we have organ dysfunction. And we're talking the kidneys, the liver, the heart, eventually the brain. So now the patient is becoming confused or somnolent because they're not getting the perfusion up to the brain. They have very poor perfusion to the kidneys, so there is not going to be any urine output. They're tachypnic, trying to increase their oxygenation because everything in their body is screaming for oxygen. Cool, pale extremities, their skin turgor is poor, and of course, very delayed capillary refill. And then we can go on to progressive irreversible shock, which increases the risk that this child is going to be lost. So we've damaged our heart, we've damaged our kidneys, we've damaged the brain. Pulse becomes weak and thready. There's hypotension that's not responding to our vasopressors. There's no urine output whatsoever. And then we start seeing a change in their breathing pattern where it's periodic, and then they're gasping, and then there's periods of apnea, and then goes into stupor and coma. What do we do about all of this? Well, the first thing you need to do is recognize that it's happening. Put the whole picture together. Don't just look at a blood pressure. Don't just look at a pulse. Look at the whole child. Look at their skin. Look at their perfusion. Feel their pulses. Take their blood pressure. Look at their tachycardia. Are they awake? Can I get this kid to wake up? Can I pinch them and make them hurt, and do they respond? Be familiar with the emergency drugs. So we use epinephrine. We can use dopamine if they actually have normal blood pressure, and then we can use norepinephrine. There's a variety of drugs. When a child comes in for anaphylaxis, we're going to give them epinephrine and we're going to give them steroids. When a child has septic shock, not only are we going to be using the vasopressors, but we're also going to administer antibiotic stat, When's the last time you had a stat order for an antibiotic? But we're going to hit them with a lot of antibiotics to cover every type of organism that we know. Of course, we've already established an airway. We want to give them maximum oxygenation and be at the ready for intubation. And what that means is you know where the equipment is on the crash cart. You know how to check a laryngoscope to make sure that it is connected and that the light source is working, and you hand it over to the doctor. We'll tell you what size endotracheal tube they need, but you have to hand it over with a stylet because the tubes themselves are very flimsy, so they need to put the stylet in, and then they'll take it out once the tube is in. IV fluids, we're going to be giving boluses of normal saline or Ringer's lactate, 20 milliliters per kilo in over 5 to 20 minutes. And so there are some kids that are in such profound shock that we are literally holding it in our hands and squeezing it in. Reassess your child. We can repeat this 3 or 4 times. Auscultate the lungs to make sure that we are not fluid overloading them at the same time. And then monitor that urine output. We'll slap monitors on this child and try and keep this kid warm and as calm as possible. And this ends this lecture. Move to part 4.